good evening, good morning, good late night, depending on where you are in the world. Today, we're going to be talking about a favorite topic of mine, high intensity intervals and health. We've got a little bit of an echo. Maybe that's coming from your background, Genie. Speaking of Genie, we're going to be introducing Genie Sandholster today. She is our new NP, a new provider with us in the channel. We've been growing like mad since we opened up for Medicare. It's interesting though, we thought most of our growth would be in Medicare, but right now, most of our growth is in the patient direct pay section. It's been very rewarding, very exciting to be able to save more and more lives. One of the interesting things that we see is that as these new patients are coming on board, over half of them have lost 30 pounds or more. And we get recurring feedback that, hey, yeah, I already lost that weight. You're saving lives. Your videos are doing it. You're saving lives from your videos even before we get in to see you as a patient. So, take a look. The information's right there. It's all out there for you for free. And that's what we put it there for. So Jeannie is going to give us a little bit more information about herself, but why don't we do that just a little bit later? Jesus, why don't you go ahead and introduce the channel and the show?
Absolutely. So it's great to be here today, another Wednesday of really interesting information, and we are talking about high intensity interval training today. I was just looking at some Facebook posts yesterday, and in some city in Mexico, they are starting a research on that on people with diabetes. So I'm glad to start seeing that on the developing world community as well as something that Dr. Brewer has known for a lot of years, and it's just starting to hit elsewhere. And we're going to talk about that and its impact on heart disease. We also have a short topic regarding CIMT and heart disease as well. We have always been talking about how it's difficult sometimes to get a good quality CIMT, but there's plenty of research that is showing that when a CIMT is done correctly, that's the standard that we should be using to detect soft plaque and even predicting the risk of having a cardiovascular event rather than stress test, of course. And on the previous topics, Dr. Bruce shared with us his CGM readings from the last month. Go ahead and take a look at that show. It's really interesting how to see how these devices work and how to interpret all this information. We had Clean Slate as a guest 2 weeks ago. He talked about his own journey on stabilizing his soft plaque. He had a couple of CIMT done. He shared his calcium score, and he shared his history, his journey through changing his lifestyle. And it's a really interesting when it's one thing to have it said by a physician, but it's another thing to have it done by somebody, by a patient. And no, it's not even a patient of ours. He's just a viewer that with just information that he was seeing on the YouTube channel, he was able to get to a really good place. And we also talked about statins and cardiovascular risk. There's always the question about where's the evidence that is showing that statins can decrease inflammation. We talked about that. People always want to see some definitive evidence on that side. It's just on a matter of ethics and logistics that it's going to be hard for you to see something like that. But the evidence is as strong as it gets. And if you want to know more about the impact of statins and cardiovascular inflammation, go ahead and take a look at that show. YouTube is our main platform, but we also have a local site and a Rumble site. So if you're on Rumble following us right now, we appreciate it. If you're on YouTube, we appreciate that as well. And if you are on YouTube, we'll be inviting you to subscribe. It makes it makes a big deal when you subscribe. I believe. How much was it, Dr. Brewer? You mentioned we were on the low 30% of people who watches the show and actually subscribes.
22%. And you compare that to some other channels, which are like 50%. So if you actually go back and do that math backwards, we currently show about 150,000 subscribers. It's probably maybe twice that or more.
Yeah. And it makes a difference because once you subscribe, which is free, you're going to get the benefit of having our content popping up on your main page from YouTube, but also it's going to tell the algorithm that this is content worth watching and it's going to be sharing that with other people. So click that subscribe button. It's going to help a lot. And we have also promoting for you to join as a YouTube member. We have had a couple of people doing that on the last shows, and they are having the benefit that if they have a question, we're going to address that first. So consider that as well. It's worthwhile. Um, the not so new prevention myths book, but it's still really good content that you don't find elsewhere. We're going to be talking about CIMT today, but part of that fundamental information, you're going to find that on the book, and how to avoid getting on that slippery slope of getting a stress test. They thinking that you are okay, and then getting hit by a heart attack it was out of nowhere, quote, or having some issue that you end up on a cath lab thinking that you are safe and then having a heart attack with a stent on. I just had a patient last week that experienced that same thing in Mexico. So it happens all the time. And if you want to know how to avoid that and really know how to prevent having a heart attack, take a look at this book. It's worth reading as well. We're working on our providers network. With Genie, we're more on a in-house work. She is learning Dr. Brewer's way of doing prevention. She's helping a lot because as Dr. Brewer mentioned, we are growing a lot, both on the Medicare side and on the direct pay side. So if you have a physician or nurse practitioner that you want them to know a little bit more, you can send them to this YouTube channel. As we mentioned, we're accepting traditional Medicare. It's growing a lot. We are having to include more providers in order to comply with the demand that we're having, and we're training providers so they know how to do prevention the right way. So if you have Medicare, go into our website, fill out our questionnaire, and we'll be happy to set you up. But if you are not in age of having Medicare, or if you're still working, even if you're in age, and you still would like to have a personalized, direct recommendation from Dr. Brewer, take a look at the packages. Go into PrevMedHealth.com. We have some options for you, and we just relaunched the packages a few weeks back, and we have seen a big improvement. It's now not as complex as it was in the past. It's very straightforward, and I'm pretty sure that it will give you the answers that you're looking for.
No, hey, since we also should do an intro slide to reintroduce the web page, because the web
Absolutely.
page is totally different. And we haven't let anybody know that.
Yeah, it's way
Touchy.
easier because it's just one button, one click away, and we will show you that next week. And this is the short topic for today. So I'm gonna present the slide, and then we can just discuss a little bit about that. So this is a study that was presented on the Journal Cardiovascular, Thoracic, and Resuscitation of 2020 on India. This is an India study, and this prospective study was conducted on over 300 patients with coronary artery disease. What they did is really interesting. They measured CIMT, they measured calcium scores, and they did also angiographies. And what they wanted to find out is on these people who already had a diagnosis of coronary artery disease, how much correlation was between a CIMT, a calcium score, and um, a stenosis or plaque detected on the angiography. The mean calcium score they found was 241. It did correlate with syntax score and Gensini scores, which are actually measurements, kind of a quantitative measurements for a plaque on angiographies. The mean CIMT measurement was 0.8 millimeters, and even that type of measurement significantly correlated with both syntax scores and Gensini scores in the angiography. And what you will see on this is basically when they say correlation is when they found low CIMT scores, low calcium scores, they found low syntax and Gensini scores. And when they found high syntax score and high Gensini scores, meaning plaque on the angiography, they found also high calcium scores and high CIMT measurements. And the calcium score was independently correlated with type 2 diabetes, syntax score, and CIMT results. Any comments, Dr. Brewer?
So from your review and from what you saw, as we've discussed, it is the standard for finding soft plaque. This looks like it's mostly correlating with progression of disease. Did anything stand out in the study about soft plaque, the unique ability for it to detect that?
Not really. Uh, they were just the one thing that I will rescue from this study is the threshold from the CIMT, because we were just discussing how cardio risk mentioned 1.3 millimeters it comes from. That's
Right.
what they define as plaque, and there's research behind that. If you look at other studies, the normal burden is below 0.8. So I was it was kind of curious to see how their mean was actually 0.8. But no, they didn't mention anything about soft versus calcified plaque, which is you're right. This is something that will have been interesting to see.
Yeah. So that's one of the things. You've heard of the term throwing the baby out with the bathwater. Maybe you haven't. That's a United States Southeast term. Jeannie, have you heard that
I've
term?
heard it.
Didn't knows it.
I have, absolutely.
So that's what we've done with CIMT. There is a major component of garbage in, garbage out in terms of trying to understand. There's an assumption that plaque is concentrically even. And Jesus, we should do a short topic on that over the next few weeks. The slides that you and I show patients where we assume that if the artery is like a hose pipe and you cut through it, then plaque is going to be lined around the inside of that artery the same way, even all the way around. That's not at all the case. Once you understand that, then you begin to understand some of the challenges and even fallacy in terms of some of the arterial age calculations and some of those estimates. Because of that garbage in, the fallacy on that piece, or the extreme difficulty in getting it in the exact place every time, the literature is the evidence is too full of that. There's too much variability, but there is literally zero. I mean, there's as little variability on detecting soft plaque with CIMT as there is variability on calcium scores. And calcium scores they're rock solid. You don't have to do much to worry about the quality of a calcium score. That's why you can get one on just about every street corner. If we had not focused, if the researchers that were doing this research had not focused so much on arterial age and that component and focused more on presence and degree of soft plaque, we'd be doing the same thing with CIMT. So it's a challenge. It's a major loss of opportunity to prevent disease, but you know what? That gives us job security work to do from our side.
Definitely, and even with calcium score, what you have seen recently, and we covered that last year, is using artificial intelligence. But of course it has its complexity. But basically, what they're doing is replacing the provider's interpretation of the calcium score and using the AI information to do that.
Yeah.
The assumption was that the provider might overestimate the results of the calcium score.
Anything else on that before we get to the long form show?
I don't think we have introduced Genie yet.
Yes, that's where I was going. So before the show, we were talking about Genie's not been on this kind of show before. Is that correct? You haven't been on this show for sure. Have you?
No,
and you don't have a YouTube channel.
No, I do not. I am a novice here.
But you do have, you are starting a little studio there because you're doing great patient care with us all day, every day, right there out of your new studio in Florida.
Yes, I am.
One of my favorite places in the world, Panama City, Florida. Genie is an NP trained in Kansas City. In fact, Genie, why don't you tell us a little bit about your background?
Okay. I am, my name is Genie Sandholster, and thank you very much for allowing me to come on the show. I am honored because Dr. Brewer is very wise, and for me to even be here, I'm humbled. But I am born and raised in Kansas City. Went to St. Luke's College of Nursing for my undergrad. Went to University of Missouri, Kansas City for my grad school and got my master's there. Have been a nurse practitioner since 1999. One thing I can say is the education I got 25 years ago and the research and the education people get now are vastly different. And you have to consistently be learning in this field. So my eyes have been greatly opened to a whole new perspective just in care alone and preventative care. These are things that physicians, Dr. Brewer does cutting edge things that physicians are not doing. They are not the mainstream, the norm, but it takes pioneers to change the system. And I think he's one of those. So I am very honored to work with you, Dr. Brewer, but I have a lot to keep learning.
Well, thank you so much, Genie. Really not that difficult to learn the basics of primary care as, as far as the standards of care in this country. Yes, we do have things set up where whether you're an NP, a doc, or a PA, you have years worth of training to get prepped for it. But then you have months worth of basically shadowing docs, and Genie's been shadowing us. The bigger issue, though, is something that you cannot teach somebody, and that is, it reminds us of that old story of I'm blanking on the doctor's name. You're not the patient's telling you the
William Osler.
Yeah, William Osler. He's one of the most famous docs in medicine in the United States. He was running the medical program at Johns Hopkins, but 100 years ago. And there's a story about him. He had a quick temper. He was running a rounds, grand rounds, where all the docs are sitting on it's the large amphitheater. The docs are oak lined. The docs are sitting there. The young doc is interviewing the patient. Dr. Osler jumps up, slams his hand down on the table, has just had it. He said, "You know what? The patient's telling you the diagnosis, if you'll just listen." And it's very difficult. That's a skill to teach providers. That's a skill that they either come with or they don't. And so at the end of go ahead.
No, I was gonna actually say a little something onto that, and I didn't mean to interrupt you, but I think that is one huge advantage with nurse practitioners because we have had to be nurses first, and we listen and we have to relay it to doctors who sometimes are very kind and sometimes they're very not. So you have to kind of learn to listen to your patients and make sure it's legit and understand everything that's going on so that you can convey that information. And it is a skill, and it is something that is very hard to teach. Both of the schools I went to were teaching schools. And I think when you are in that arena, you learn that there's always opportunities for learning, and to think that you've arrived, or be arrogant in that thinking is wrong, because there's constantly learning. And I think that is one of the things I see you do so much with your patients. Sometimes your patients, when I'm following you, I am shocked at the level of knowledge that they have and the research that they've done. And you know, you are always gracious to them with that whole situation, as they're telling you all that they've done, and you are listening to them. So it's very encouraging.
Well, that's where I was going with you. That's what I like. That's what I see when we're recruiting providers to join us. It's not so much what you already know; it's your ability to listen, and that's what separates a good provider, a good doc, a good nurse practitioner, um, from a mediocre one. And so I've been very impressed with the way you listen, the way you interact with patients, and that's the hard part. You can't teach that. Thank you for what you do.
Appreciate it very much. Thank you.
And Genie is a pretty fast learner, so we're glad that you're in the team.
Great.
Okay.
I'm glad to be here.
So this is, again, what we're going to be talking about is one of my favorite topics. Is high intensity interval training. As Jesus started to mention, I think a minute ago, insulin resistance is notorious for decreasing capillary penetration to the muscle mass. And that's a big deal, because muscles are our major internal safety valve against insulin resistance. We tend to lose that capillary penetration of our muscles, that muscle microvasculature. The best way, bar none, to retain or start to regain that microvasculature, that capillary penetration of muscles, is high intensity intervals using that specific muscle mass. So especially at age 60, in your mid 60s, loss of muscle and muscle metabolism, metabolically active muscle, does appear to be one of the major underlying mechanisms for aging. So if you want to learn how to stop aging, one of the keys for it, listen up. That's where we're going. If you'll give us the water ball, we'll get there. Go ahead, Jesus.
Sure. So, this is a study that was published on the journal Circulation from the American Heart Association on March of this year. And they're mentioning that there is some evidence that suggests that middle-aged and older male athletes have increased coronary artery calcification and atherosclerotic plaque related to the amount of intensity of exercise. Meaning, they're starting from the thinking that exercise might be related to calcified plaque. But they're seeing that as a bad thing, and we're going to discuss more a little bit about the conclusions of this article. They used information from the MARC1 and MARC2 studies, which are cardiovascular risk studies on athletes, and the prevalence and severity of calcium score and plaques was determined by angiography. They measured both volume and intensity of exercise with metabolic equivalents, or MATs. And the idea is trying to identify if volume and or intensity of exercise has any impact on the development of plaque. The others included 289 participants. They followed them for 6 years, which is it's a really good time for follow up on these types of studies. It's hard to find some place where they follow them for more than 10 years, but this is really good. The median calcium score increase went from 52 to 71%, and the exercise volume, once they did all these measurements, the exercise volume, meaning how often did exercise or how much time they were exercising, was not associated with any change on the calcium scores. Vigorous intensity exercise, that they said that vigorous was between 7 and 9 metabolic equivalents, was
Or Mets.
associated, or METs, was associated with lesser increase in calcium score. But this is the key thing here. Anything above 9 METs, meaning very vigorous exercise, was associated with an increase on the calcium score. So if you see here on this chart, this is what they're saying basically. And even the increase is what, like 0.05 on that standard. It's kind of interesting to see that, and this doesn't tell us this, if this is soft plaque. This is very likely to be calcified plaque, and this is key, because when you
Let's,
see,
I'm sorry, go,
uh,
before we go, let's talk about that. Can we go back to that last slide for a second? Just
sure,
a little bit about the stats. What that's called is a whisker plot. And the large dot in the middle is the number that they saw. The whiskers on either side are usually going to be the 2 standard deviations. So as you see, exercise volume ended up pretty close to no change, especially when you look at the whisker went all the way out on the left, and the zero change line was very close to the finding. Exercise intensity, moderate intensity, you see the same thing, very close. Now on vigorous intensity per 10%, it's in yellow, so it's a little bit harder to see, but it dropped in terms of progression. And that looks like it's statistically significant because the whiskers do not even cross over the no change line. Very vigorous intensity per 10% on the red one. Same thing. The 2 standard deviation does not cross over the zero change line. So that's how to interpret those. Any other comment on that, Jesus?
no, and I just made the screen bigger on my right side so I can see it better. Yes, you're
Okay.
right. Okay, so I wanted to show you this one because different to the short topic study, they did compare with the angiography and identified the type of plaque that they were measuring. And if you see here, we have multiple columns with the whisker plots that you just mentioned. And if you go into the one that says any plaque, the evidence says that it is very likely to develop any type of plaque once you are in a very vigorous intensity. But let's go then to the C and D charts, right to the right, and you will see how the impact is mainly on the calcified plaque that you see over there. It goes into the 2 standard deviations. And if you move further to the right, mixed plaque, which is what we call heterogeneous plaque, it's basically on 1, meaning there is no impact. And if you go even further to the non-calcified plaque, it stays on 1, which means there is no impact. So what they're saying is very vigorous exercise correlates with calcified plaque. And we know that calcified plaque means a stable plaque.
So I look at that from our background and I say, what it would indicate, it looks like it indicates to me what I would expect, and that is vigorous exercise is helping them calcify and stabilize their plaque. Now, a couple of questions about the authors. You mentioned that their basic study question was, okay, does vigorous exercise, athletics, does it increase your risk for cardiovascular disease? That's the question they're asking, correct?
Yeah, the perspective is high calcium score means high risk.
Now,
That's the hypothesis, right?
go ahead. Okay. Yeah, I think you're going to where I'm going next. Go ahead.
Mhm. So this is what I put there a couple of key questions that I thought that those that were the things that you want to mention. So what the
Yeah.
author said at the end was the acceleration in coronary artery calcification attributed to very vigorous intensity exercise might reflect an increase in plaque calcification. So we're good at that side. The clinical relevance of these findings remains unclear, but the impact of cardiovascular risk associated with coronary arteriosclerosis. That's where there's and I think I missed one key word there, but what they're basically saying is we are not 100% married with this result. We're just saying that maybe very vigorous intensity exercise increase the risk of cardiovascular events because there's more coronary artery calcification.
So, like most medical people, they don't understand that when you stabilize soft plaque, it calcifies, and therefore it's going to increase your calcium score.
Yeah, and they did not make the recommendation, but the language sounded like they were like saying, okay, do intense exercise, but not very intense exercise.
Mm.
But they didn't say that, so I'm gonna give that because they were on the conservative side of saying, well, these are our findings. Let's research more, but it's good evidence.
Well, study authors, like everybody else, and especially study authors, approach their science with their own filters. And you've got to be able to see through that filter and understand, what's the data really telling you?
Yep.
Very interesting study.
So the key questions maybe you want to address that. What does a high calcium score really means? And I was just chatting with Genie before the show and mentioning her that in our perspective, a high calcium score will mean two different things on a person who is not doing any lifestyle changes versus a person who is actually doing some lifestyle changes and even on some medications like statins. And even the same number might mean different things.
So I didn't understand the question. I think I know where you're going with this, but I didn't understand your specific question to me.
If you want to elaborate on what do you think when you see a high calcium score?
Well, let me start with one of the most common problems that I see. Somebody learns about calcium score. Their doctor may or may not know what it is. They go ahead and get one. One of the most common reasons for coming to see us is they find a high calcium score. We get plenty of people, calcium scores 1,000, 2,000. We've even got a few people with calcium scores over 4,000. I've had more than one, males, especially in my age group, boomers, we're taught from day one, don't cry. Yeah, that's not, men don't cry. And when you start talking about your calcium score, you start thinking, you know what, this, especially if your calcium score is 2, 3, or 4,000, you start thinking, this might mean I'm going to be dying soon. And so I've had plenty of them cry when we get to that discussion. Usually, always, we haven't had a patient yet who came to us with that very concern, who wasn't feeling great usually within 6 months. They understand a lot more about the process. They understand about what this actually means. And it's a whole new ballgame. Yes, there's risk. There's no question about that. But one of the things they begin to understand is that they're at far less risk than they were prior to that increase in the calcium score. The other very common thing that we see is somebody comes in, they have a positive calcium score, they lose 30 pounds, they get in a whole different area in terms of their risk. They go back expecting their calcium score to decrease, and what happens?
It goes up.
It goes up, and it goes way up, and it's because with CIMT, with our body, calcification means that you're stabilizing your plaque. Unfortunately, most doctors don't even know what a calcium score is, let alone knowing that calcification of plaque also means stabilization of that plaque. So we end up talking a lot of people down off a ledge when those calcium scores come back increased. But you can literally see that. You can watch it happen in a CIMT as somebody goes through this process. Now, so it brings up what's the word I'm looking for? Something that looks like it's not an irony, something that looks like one thing, but actually it's something else.
I don't know. Genie, do you have any idea?
Looks like something, but it's actually something else.
It's like
I don't know what.
It's ironic.
It is like irony. Mm-mm.
But there's another word for that. So if we said, well, let me ask you this question, Genie. If we said, okay, these people are more stable now that they've actually increased their calcium score, why is it the common knowledge out there that an increased calcium score means increased risk for cardiovascular disease?
Probably because they don't
put you on the spot or anything, but
I think that probably because people aren't understanding the physiology of what an increased calcium score means and hardening the plaque as opposed to the soft plaque, and the soft plaque is more risky than the hard plaque. And that's why I think you spend a lot of time explaining that so people understand that, because I've watched patients say they want another test, and I've watched you talk them off the cliff to say that it's not going to actually encourage them, but it is actually encouraging findings.
So given that, and for either one of you, is it better to have a 0 calcium score or a positive calcium score?
I'm gonna go ahead and say that it's better to have a positive calcium score.
Really? Tell us why you're saying that.
And I'm gonna telling you why. Because a positive calcium score, if you're not doing any lifestyle changes just yet, it means that you're developing calcified plaque, but for the wrong reasons. Any calcified plaque means you started with soft plaque. So if you have calcified plaque, means that you're very likely to have soft plaque in there. And if you have soft plaque developing, you wanna know. If you have a 0 calcium score, it means you don't have calcified plaque, but it doesn't mean that you don't have any soft plaque. You might have a lot of soft plaque right there that is just not stable, and you will go with the false idea that you're safe.
But medical science is full of the assumption, and you'll hear this multiple times when you go get a calcium score. It was 0, you're fine. And in fact, if you look at the standards committees, they have actually started to look at calcium scores. And the American Heart Association Standards Committee has now said, look, if you have, we know we talked about statins and statins based on LDL level, but it's true, if you have a 0 calcium score, you don't need to take a statin. Even the American Heart Association Standards Committee said that. Now, why are they saying that?
I'm not sure. That's something that I won't agree with, but go ahead.
Well, see, it's interesting, Jesus. You've got an unspoken assumption going on here that the patient has plaque.
Yep.
And therefore, if there's no calcium, it's got to be soft plaque. And if that assumption is true, that they have plaque, it's better to have calcified plaque than soft plaque. But what if the patient does not have any plaque at all? What if it's a 30-year-old that's in great shape, has no plaque.
I'll go ahead and say if there's a CIMT that is negative, no plaque on the CIMT, no
Right.
plaque or zero calcium score, then I will go ahead and say yes, you don't need a statin or aspirin right now. But
But
I'll go get a CIMT first.
well, that was my point. So that's why are you getting a CIMT? To prove that they have no plaque.
Mm-hmm.
So that's where some of the confusion in logic comes, and that's why this can be confusing. That this whole issue of, well, first of all, do you have soft plaque? That's the real question, because hard plaque doesn't really confer that much risk. Why does an increased calcium score confer risk? Because the patient has gone through multiple episodes of laying down plaque and going back and body stabilizing it. If they've gone through multiple episodes of that, as evidenced and shown by a high positive calcium score, then yes, they've got more risk than somebody that doesn't have any plaque. To your point, Jesus, those of us who know this space got a little bit nervous. It was a sort of a bittersweet victory when the standards committee said, no, you don't have to take a statin if you got a zero calcium score. And here's why. It was nice to see them acknowledge that calcium score is a great item to use for measuring risk. However, they missed your point that, you could have a zero calcium score, but still have soft plaque in there. I did find some studies, and I covered those on a video a few months ago, where somebody asked this question. They said, well, what if you have a zero calcium score? Could you still have risk for heart attack? Guess what the answer was?
Yes.
Yes. So, the standards committee at least started acknowledging that it's plaque. It's not just LDL. They started acknowledging that calcium score is a great tool, but they still missed it on something that you two got immediately. You could still have nothing but soft plaque, and that soft plaque can kill you.
And we have seen that.
Very true. And the word, I think.
I'm sorry, Genie. Go ahead.
No, go ahead, Jesus. Go ahead and finish.
I was just going to say we have had patients with zero calcium scores and some soft plaque.
Absolutely. We had one this week, didn't we?
Yep.
I was going to tell you, Dr. Brewer, I think the synonym for irony you were wanting is paradox, correct?
Paradoxical. Thank you very much. That was it.
Very welcome. Okay.
And to your point about our patients being sophisticated, yes, a lot of our patients are doctors. We had one yesterday that's a radiologist, very, very smart in this area. Tried to go to her internist to get some of this done, and she recognized immediately that her internist didn't know, so came to us. But yet, our patients don't have to be docs. The vast majority of our patients, especially on the direct pay side, understand the value of what we're doing, and they know more than 90 to 95% of docs in this space. Very, very.
Well, I know. I was with you on one that was someone who was an engineer, and he had his graphs prepared and all of his everything plotted, and he had done a lot of work, and
Yes.
it was very impressive. Very impressive.
Our typical patients know a lot more than 95% of docs about this space. Jesus, you want to talk about high intensity intervals and heart disease?
Yeah, I went ahead and I was like, the previous study mentioned very vigorous exercise, and I was kind of getting ahead on saying, well, how do we know that's HIIT? Where's the research behind HIIT, high intensity interval training? So I found another. This one is a small study, granted, but it's on the European Journal of Preventive Cardiology of this year as well. They studied 66 patients in 2 randomized weekly supervised HIIT sessions, where they are getting to 85 to 95% peak heart rate. And they evaluated atheroma, meaning plaque, volume using angiogram and intravascular ultrasound. Another method to measure plaque, more invasive, but it's another method. And they found that in patients with established coronary artery disease, the regression of plaque volume was observed after 6 months of supervised HIIT. Now, when they say regression, and I know you have a comment on this, Dr. Brewer, and I don't want to steal your thunder, but I have it on my mind right now. When we talk about regression of plaque, we're basically saying we're taking out not calcium, but a lot of that inflammation liquid that comes with the inflammation process of developing plaque. And that's why they're seeing regression. Is very less reduction in inflammation within the intimate layer of the artery wall.
Well, thank you for worrying about stealing my thunder, but if you steal my thunder, that means that we've got more people who can do what I do. That's a good
Well,
thing.
I'm just hoping to be able to do what you do on Spanish. But yes,
Again,
we have a lot of population to cover in Spanish, though. Any other
that's
comments
her
on this
dad.
one? This is a really good study. It's a small study, and I think the value behind this one is they did went ahead and supervise the training, and this is something similar to an institution of Mexico is doing right now.
The other
So,
comment, you asked for a comment. The one comment I would say is regression is fantastic, even if it's not getting rid of, even if the LDL, the small dense LDL, or the cholesterol is staying in the artery wall, even if the calcium's staying in, if you're getting, if you're pulling out that inflammatory liquid, the cytokines, the antibodies, the enzymes associated, and most of all, the liquid and the cells associated with an inflammatory process, you are stabilizing it. So that's exactly what you want to accomplish.
I think Genie was getting ready to say something.
Uh-oh.
well, it was just interesting though that they were using intravascular ultrasound. So then they were measuring it with intravascular ultrasound, like under fluoroscopy or something. Is that how they
Yep.
were assessing
Yeah.
it?
Yeah. They use the angiogram, and they also I don't know what's a kind of a fiber scope or something like that, but I mean very more invasive, and I think they didn't want to have any risk of not being able to detect that. I think it's a really
Yeah.
interesting technology, very invasive, but really interesting.
That's a
Well,
picture of it right there.
I
Yeah.
see that, and I put PICC lines in for very many years, and so I'm very familiar with vasculature and ultrasound and placement. But when you put something in arteries, a whole different response comes than when you put it in a vein. So I just wondered how they were able to do it, but that's very interesting.
That's for sure.
And that is a very interesting background. Okay. I tell you what, if you'll give us the transition, we'll go into Q&A. That's the favorite part for most folks because it's more like a conversation with our viewers. There we go. And you know what? I can't help but acknowledge it again. Dr. Vega has taken control of the Q&A.
I'm ready ahead of you.
It's a power thing with him. He even he figured out, I don't know how he did it, but he figured out how to take my connection out. So I'm just a visitor now.
Oh, I didn't do that.
Yeah, you think I believe that?
I would like to take the credit out of that, but I didn't do it. I blame Gilbert.
There we go.
So GNA $10 super sticker. Thank you so much. Those go a long way. Those help a lot. As you know, I'm in Mexico right now. Gilbert is on the Philippines. We have a team on the Philippines. We're growing rapidly. And yes, YouTube is not our main source of income. You have to know that. but is the main source to comply with the vision of Dr. Brewer sharing this information. So, building a YouTube channel as Dr. Brewer has done so far, it takes time, it takes effort, and it takes money. And Dr. Brewer has spent a lot of that on this, and any help is really appreciated. Um, I do have a couple of just greetings to go over first. Just Rusty, greeting from the trail, decided to take the rest of the day, and he was fortunate to see the show today. Bart Robinson. I believe this is the first time we see a picture of Bart, right? Maybe this is a
Well,
stock photo, but I don't know. I haven't seen another one.
yeah, I don't remember seeing that either. It's changed, no matter what. Thank you, Bart.
Um,
This
Bob,
next comment from J and A. Can I respond? Oh, well, go ahead. Go ahead.
you want to see? Okay, here's that's Bobby Ocampo saying Mabuhay Mahab Bang Buhay, life and prosper, live life and prosper, something like that. Was it?
Yes. Good life, happy life, live life, and prosper. You didn't
Good.
know I spoke Dipalong, did you? That's from the Philippines. I don't. I speak Spanish better than I speak Dipalong, and my Spanish is really bad.
No, it's not as bad. It's really good.
So can I respond to this?
Sure, it's your
So
show.
J and A. Oh, that's right. Forgot. So you just it's my show, but you took it over. So J and A is making a point. He said, "Good morning, all. Dr. Brewer, you demonstrated huffing and puffing for for high intensity interval trainings. I don't seem to get to that point. Instead, I get a good increase from heart rate. Will that work for HIIT? Thanks, Jerry." So, Jerry, here's the point. When your heart rate starts getting your maximum minus 15%, you're going to start breathing heavy. There's no question about that. So, I can't really demonstrate my heart going fast. What I'm pointing out is in aerobics, it's a very common thing to say, oh, you want to be able to increase your heart rate, slow jog, fast walk. You want to be able to talk to a friend. You want to be able to maybe sing. If you get to where you can't do that, you're not in that. Some people start calling it stages 1 or level 1, level 2, low level aerobics, whatever. Those are aerobics. And what I'm trying to point out when I do this is that if you get to an intense interval, you have high intensity intervals are very intense heart rate followed by slowing down and rest. So the intense phase versus the rest phase, put those together, that's one interval. And my point with all the heavy breathing is not to create a whole new kind of YouTube channel. My point with the heavy breathing is to demonstrate you can't hum, you cannot sing, you cannot talk to somebody else if your heart rate is going your maximum minus 10 to 15%. You just can't do it, even for 1 minute.
Yeah, and the other thing is we talk about physical condition as well.
Mm-hmm.
So when you are not there yet on a good physical shape, you're very likely to have your heart rate increase faster than the usual. But as you keep training, you're gonna get to a point where you're gonna be able to tolerate more intensity without a really high increase on your heart rate. But that takes months or years to
You
achieve.
bring up a good point, and they start saying, well, for somebody my age, I'm 65, the rate should be 130 or more. Age does impact it, but your point impacts it almost as much, if not more, in some cases. I can routinely get up to 150. We've got plenty of patients that are in their mid 60s that do that. Some patients in their 70s who do that, and it's because they've done exactly what you're talking about. They've been doing high intensity interval training for years.
And there's a quick mathematical formula to know your limits. We consider 220 minus h. That's
Right.
the maximum heart rate to achieve. And if you take you reduce that on 20%, you get to 80%. And
Right.
that's actually something that is used on stress tests. And you can use that information to do something more useful, which is a high intensity interval training. You can try or guess what your limits are um, with that. Um,
So let me make one other comment. One of my very first videos, 5 or 6 years ago, on high intensity interval trainings dealt with the point that you're talking about in terms of conditioning. Some people whose exercise involves walking around the block or going to the mall and walking there, um, they're not going to be doing hill runs on treadmills or significant hill work on a exercise bike or a road bike. But the goal is to train into as far as you can get. But that doesn't mean that they can't get their heart rate elevated. It doesn't. You don't want to go from a mall walker level to trying to get 150 beats per minute. But you don't want even a mall walker to think. Here's one of the more common errors. Somebody that's a mall walker level, and meaning a very flat walk. That's their version of exercise. Thinking they're doing high intensity intervals while they're able to talk to each other. That's not a high intensity interval.
yeah, and the key with HIIT training also is that you don't have to do that every day. So
You don't want to do it every day. Three
and you
times
might
per
not be
week
able
max.
to do that. Yeah, exactly. 3 times per week or even 2 times per week, and it's just saying that this should be part of your exercise routine because we show that there is evidence of the impact on inflammation and cardiovascular disease, specifically from this type of training. Even from there are moderate intensity interval trainings as well. That's been described, and it has some impact as well. So even if you don't get to a HIIT training per se at the beginning, you can try something on a lower intensity.
Yeah.
But it's part of your adaptation to a lifestyle. As Dr. Brewer said, we don't want you to go from 0 to 100 miles per hour just immediately. Ricky the Gun. Ricky the Gun is a YouTube member, as you see there on the logo right next to his name, and we appreciate that. Good morning from NC. When someone says they have 20% blockage, is that solely an inflammation of the vessel, or can it be where a small bit of ruptured plaque is attached?
Genie, what do you think?
I think that it could be both, actually.
Yeah.
Am I correct?
Explain a little bit more.
I think that when someone says they have 20% blockage, is that only inflammation of the blood vessel, or can it be where a small bit of ruptured plaque is attached? I mean, plaque's going to attach to the walls anyway, so the blockage could be that there's just more concentration in that area, is what I would think there.
The one thing that I'll be worried is whenever you have ruptured plaque, you're very likely to be developing a heart attack.
Right.
I haven't seen ruptured plaque without symptoms. It's usually when it gets ruptured when you start seeing all of this, because the clot is just going to invade as much as possible.
You're bringing up a good point. The term ruptured plaque usually is referring to a soft plaque that's got a little bit of covering over it. The covering ruptures, the soft plaque goes out, and that's the stuff. It's not plaque that causes the heart attack; it's the clot. And soft plaque touching flowing blood is what causes that clot.
Exactly
So
right.
there's a whole lot in that question. Some things which
Yeah.
start taking it in a different direction.
And you may even have calcified plaque that is covered
Yes.
20%. And that's what happens when you get a carotid ultrasound. and they're focused more on the blood flow and measuring the speed of the blood flow, and they're saying, oh, you have a 20% stenosis or blockage, but it's all calcified, but they're worried because you have a 20% blockage. But if it's calcified, I mean, that in itself means that's a stable plaque.
Yeah.
um
And one of the studies that you described today talked about mixed plaque. It had calcified plaque and non-calcified plaque, and then it had mixed in the middle. This thing about mixed plaque is far, far less common than people think. They think that's what most of what we get. No, soft plaque is somebody whose lifestyle is out of control. Some things are going very badly for that person. That's not incredibly common either, but that's what's happening when somebody does have a heart attack. They've got a lot of soft plaque, and one of those ruptures. Um, the goal is to get your lifestyle back in control, decrease your body fat, because body fat drives this process, and get that plaque back to where it's stable.
and I'm gonna bring
I do have a
make it
question on
sure.
that. I'm sorry, Jesus.
No, go ahead.
How can they tell that it's ruptured plaque versus soft plaque? Are they able to determine that in some type of test?
Hey, sis, you want to take that?
That's what I'm considering, because I haven't ever seen a patient with ruptured plaque without symptoms.
Right.
And even an electrocardiogram might tell you that. You see an elevation of the ST segment, which means acute injury of the vessel on the wall, and that's basically related to the ruptured plaque. So you can even see that on an electrocardiogram. That's what you do on the ER. Um, uh, you can see that. You can see that on the on how do you call that, the
Autopsy.
yeah, and then you see
Yeah,
that,
I was
oh,
going to say.
it was a heart attack. Yes, of course
Uh,
it was.
I was going to say it's a gruesome reminder or picture, but the vast majority of images that you're going to get of a ruptured plaque are going to be on autopsies.
Yeah, usually
Right. That's why I was wondering how was that seen prior to,
No,
I mean,
it isn't.
Yeah, that's almost more of a theoretical concept.
Yeah, and one thing that I want to mention, I know we have taken a bit of time on this, but this is the reasoning behind you don't want to use a stress test to predict cardiovascular disease. They will tell you that there's obstruction up to 50% or more than 50%. They're gonna miss anything below that, and anything below that might be all of that soft plaque, and you'll still have risk. So be careful about that.
The Princeton University Prevention Center was very clear. I mean, they had some great images and content about that. 2/3 of the people that have a heart attack have less than 50% flow impact. If you have less than 50% impact on flow, you're going to get a negative stress test. So the vast majority of heart attacks are going to be missed by a stress test.
That's a summary of the book right there.
That's right.
Bob Ocampo, and I wanted to address that because you did address that.
Don't have to buy the book. Don't have to spend hours reading it. You just got it right there.
You still want to read it. There's more information just than that. But that's the key one. Bob Ocampo, how is HIIT related to autophagy? And you did respond to that question. And that's what I wanted to address that. HIIT replaces muscle microvasculature lost due to insulin resistance, and it regrows capillaries. So that's basically the concept in there. And even there's some studies that they're talking about decrease of inflammation as well related to HIIT. The mechanisms are not well understood yet, but we can cover that later on. We have a couple of comments from people who are YouTube members. So I'm going to address this one because it's related to the answer from one other person. Even though JMK, even though my cardiologist knew I was a type 2 diabetic, he strongly recommends that I go on a Mediterranean diet. Doesn't a Mediterranean diet contain breads, pasta, fruits, and vegetables? And Jay Pitard says, A key to Mediterranean is eating greens and fiber first, then protein, either with fat and carb or before fat with carb last. When we just eat foods without the cultural sequencing, it helps less. So it looks like Jay is saying the order on what you eat stuff impacts what you're eating. What do you think, Doc?
Well, he sounds like one of my rants. If you want to get a little bit more perspective on the quote Mediterranean diet, read the book The Big Fat Surprise by Nina Teicholz. She, in a couple of chapters, she goes into the whole idea and the marketing concept, etc. I don't like the Mediterranean diet. I don't recommend it. And I know I'll get plenty of hate comments for saying that. But it's exactly the reason. Can you go back to the first one?
Sure.
It's exactly for that reason, JMK. People, there are grapes, therefore grape juice. There's a whole bunch of grains, breads, other grain products. In other words, if depending on how you interpret the quote Mediterranean diet, you can eat a diet full of carbs. For those of us who have problems metabolizing carbs, and that's only half of us age 30 or older. So, if you're feeling lucky, that's most of us. I mean, most of us have a problem metabolizing carbs safely. To recommend a diet that can be interpreted to be so full of carbs is just not good for our health. And while I'm on this rant, I'm gonna make the comment about whole grains. What's the how? We're getting some voice in the background. I'm not sure where that's coming from. Jesus, how long does it take to? Well, what's the you remember the glycemic value for whole wheat bread versus white bread versus sugar?
Oh gosh, we covered that a few weeks back. I don't remember right now.
Table sugar is not glucose, it's sucrose, and the glycemic value, in other words, it impacts your blood sugar in a score of 50. White bread is 75, so it's worse than table sugar, and whole wheat bread is like 65, so it's worse than table sugar. So, and people are going to see the term whole grain products and say, well, it's whole wheat bread. They're right. And yeah, whole wheat bread has a higher glycemic value than table sugar.
Yep.
They turn around and they fear table sugar, and they think they're eating healthy when they eat whole wheat bread, which is right there, one of the staples of a good, quote, healthy Mediterranean diet.
Well, I looked up the glycemic index of pita bread because Mediterranean people, I'm Lebanese, so I know some of this. They eat pita bread a lot, and pita bread is 68 on the glycemic index. So even pita bread, which you wouldn't think would be full of sugar, is full of sugar. So if you eat vegetables and baba ganoush, which is eggplant dip, then you're probably a lot better. But if you start eating it with pita bread, you're not.
Yeah.
So there you go.
And we're meant to cover glycemic index. I'll put that for next week. I have it on the queue.
So here, I forgot to mention, you're from the Mediterranean. You know that space. It's your family culture, and you're right. We got to be careful about how we interpret stuff, how we define it.
Well, and my mother, both her parents are Lebanese, so I'm half Lebanese, but even when my mom would make certain things as a kid, we ate a lot of eggplant, and like we didn't necessarily have spaghetti, we didn't have noodles, we had a dish that had a red sauce and some ground beef and some eggplant and like layers. And so it was they whole true Mediterranean eating is very different than the American Mediterranean eating.
Yeah.
That's
In what
a key
way?
concept.
it's more whole foods, more fruits and vegetables, more, there's a lot of eggplant, there's a lot of, tomatoes, there's stuff that I don't necessarily like in it, but like, I mean, there's kibbe, which kibbe I not my thing, but I know it's meat with wheat, but it's whole wheat or something, but not my thing. But they eat a lot of whole yogurts, a lot of lemon juice, tons of garlic, stuff like that. So the American version is like bringing, the grapes and stuff and nuts, but in the Mediterranean, there's a lot of pistachios and things like that that aren't kind of on the American side, and not a lot of processed either.
It sounds like there might be a significant increase in carbs as well on the American version.
Absolutely.
Yeah. And you covered some about the food pyramid, Dr. Brewer, in the past, and there's a history behind that, right? I think it was prior to World War One or World War Two when it was being proposed whatever was cheapest to feed the population due to economic issues, and that is actually grain products.
Absolutely.
So, and it stayed there.
It is, grains are easy to grow. They're cheaper. They store indefinitely. And, you go back and you read Guns, Germs, and Steel from Jared Diamond. He makes a really good case that the first civilizations to access grain products, grew their population, grew their army, and took over. But with every strength comes weaknesses, and now we're dealing with a weakness that as we age, we really can't metabolize carbs so well.
Chris Linky, I noticed that in one short, Dr. Brewer recommend 400. I believe that's micrograms of
You're
K2 a day.
correct, not milligrams.
Can that be broken into 2 doses, or should it be all taken at the same time? I don't think it matters. Do you?
I think you're absolutely correct. It does not matter.
Paul Railsback, I'm 80 and routinely get to 160 to 165 beats per minute doing HIIT, and a calcium score of 1500. Really good.
You're knocking it out of the park, Paul. Do it. How are you getting how are you getting up there? Is it hill runs? Is it bikes? What is it?
Really interesting to see that. And the other thing is, consider that you might not want to jump off a cliff because of calcium score of 1500.
Yeah,
and consider that if you go ahead and measure the calcium score again, it might go higher. So better follow up with a CIMT, and also, of course, all the lab work that we recommend, Dr. Brewer, on detecting insulin resistance, having an inflammation panel done, going to the root cause. HIIT is going to help a lot, but it's just part of the process. Let me see. Bobby Ocampo, is swimming without breathing considered HIIT?
Go ahead.
I don't know. I think it's not just the lack of breathing. I think it's swimming, of course, but yeah. I'm not sure.
Yeah, I think that part of that is confusing, and JMK pointed out part of what I was creating and contributing to some of that confusion about equating being out of breath with a high intensity interval. And when I'm doing that breathing component, again, it's not to talk about breathing. Yes, you swim underwater and you're going to be out of breath. You could swim very slowly, get out of breath. You could even hold your breath, go underwater and not swim, just stay there. That is not a high intensity interval. The high intensity interval is creating major draw for oxygen from your muscle tissue, and stressing your cardiovascular system to replace that oxygen. So it's not holding your breath is not the same thing.
Paul Raceback, he mentioned that he's doing HIIT with biking
Give me a second, biking.
and
Oops, I'm sorry, I'm doing that.
that's why I have the control, Dr. Brewer.
Rucking. You want to talk about rucking? I still do a little bit of that, and in fact, why don't you start talking about rucking? I'm going to go get my weight vest.
Uh, Unfortunately, I don't have so much experience on rocking. Do you, Genie?
I don't know what rucking is.
I
Jesus,
think
what is rucking?
I'm not sure. I haven't done that.
It looks like it's a simple walking or hiking while carrying a weighted backpack. That's why
Yeah.
he's going to get his backpack. It's a staple
Wow.
in the international military
Oh
training of
yeah,
soldiers.
that's right.
Yeah,
Yeah.
So
got your
this
backpack.
backpack, you can fill it. It's got pockets. It's very, as you can tell, I'm going to set it on my standing desk. I'm afraid it might flip the whole thing over, but it has these pockets, and in the pockets are these little sand packs. So this vest weighs about 60 pounds, and you basically put it on, and then you go walking in it. It gives you an interesting thought about, wow, if I were to gain 60 pounds, this is what it would feel like every time I went walking. But rucking is a very, it's not, well, you can do intervals with it. It's not quite the same thing. Usually it's not quite the same thing, but if you do like when you go up short hills, you can get an interval in there with it as well. Rucking, I think, is a really good exercise. I think it really helps, especially in terms of people who are having challenges with maintaining their bone health.
The other day at a beach access close to me, there was a good hill in the soft sand. Carrying the cooler and all the accessories was a real good HIIT training to go up that hill. So.
Yeah, sand going up a hill of sand is a big deal. It's a great form of high intensity intervals.
Sounds like it. I've never done that. I'm more like on the sports side. I used to train a lot in soccer. Dr. Brewer is a former soccer player as well, so he knows what I'm talking about. And I used to use some weights, but in the ankles, until I learned the impact that it had on my ankles. I just stopped doing that. But I didn't know about rocking and all of that. Sounds really good. Drugs of the North. Is it worthwhile having a calcium score of CIMT 10 years after a CBBG? Not sure. What is that?
I think he's talking about a cabbage. I think he probably meant CABG, coronary artery bypass graft. What do you think, Genie?
Oh, okay.
Yeah, I think he probably meant cabbage there too.
Okay.
Heart attack and 2 stents.
And 2 stents. Neither of these have ever been offered. I was not familiar with that acronym. We do recommend CIMT every year, though, for follow-up.
Yeah, CIMT for sure. There's some question about when you can get a calcium score after a stent, because you've got that stent in there, and there's some disruption of the calcium plaque pickup.
Yeah. Do you think the cabbage though was before the stents or after the stents because the stents failed?
I don't know. It's a good question.
Yeah. Do you ever recommend a follow-up calcium score, Dr. Brewer? I haven't seen that.
Follow-up post what?
Like they have a baseline calcium score and then go ahead and get a new one.
And I don't argue at all with the standard, and the standard recommendation is 5 years. I don't have a problem with that. The concern that I have is so many of our folks are so hyper about their health and wanting to measure it. They'll get them like every year. There was a fellow that ran the channel for a while, a fellow named John Lorscheider, extremely smart, and he was very comfortable about getting these fairly often. And he's one of our very few guys that clearly demonstrated a decrease in calcium score. And I'm convinced it was real. He came to us. He really didn't look like he had significant weight to lose, but he shared his story. His he was the one that said, "Look, I started asking him about glucose metabolism, and he stopped and he said, "Look, I know you're if people are, you can be a hammer, everything looks like a nail, and if you're a hammer, you're a pre-diabetes hammer. I can tell you, my doc checks my my A1C, checks me for glucose metabolism every 6 months, and I don't have it. I check on him because I wrote he wrote a very sophisticated health maintenance channel or health promotion channel for years, and he did focus on that. But he said, but he's a great guy, nice guy. He said, okay, but I'm going to humor you, and I'll go ahead and get this test. He got a Kraft insulin survey, and it went up to like 350 peak, his glucose. So he clearly had not minimal, not pre-diabetes. He had significant diabetes. He took this information to his doc. His doc looked at the information, shook his head, and said, "You still don't have diabetes. These tests are rigged to fail." And it's like, what? And that's the typical what you see out there. But now, why did I go down that bunny hole?
You were trying to talk about his score improving.
Yeah, having a score every year.
Oh, okay. So he's a very smart guy. And again, thank you for reminding me. So the point was, he got him he was getting them like every year or so. Other people criticized him, saying, "Oh, that's too much. You're going to get." And the bottom line is that was crazy. He knew more about that than they did. You don't get that much radiation from these things. Each year they continue to improve the technology on it. And the risk associated with radiation from a calcium score is zilch. It's totally ignorable compared to the risk of what we're talking about, what we're measuring, heart attack and stroke over the next 10 years. It's just, anyhow.
Really interesting stuff. Mesnin, as a 58-year-old lifetime runner, I run a steep incline sprints of 30 seconds to a minute with 90 seconds rest 6 to 10 times. Those look like 10 intervals, right? Heart rate reaches 156 to 165 and returns to 78 to 80 in a minute. That's really good. However, difficulty recovering in days afterwards. Yes, that's the impact of a HIIT training, and that's what we're talking about. Physical condition. 58 lifetime runner. You are training your body to get to those places, and you might even have resting heart rates below 60 when you are used to this type of exercise in the long term.
It also speaks to that point about, these folks that come in and say, no, I do high intensity intervals every day. Well, I mean, if your version of a high intensity interval is you can still talk to somebody while you're in the intense phase, then yeah, you can do those every day because it's not really, you're not reaching an intense level. And that's not stimulating your muscle vasculature, which is the whole goal.
And the other thing, muscle fibers and vessels usually grow during rest, not during exercise. During exercise, you are creating the demand. Right. And while resting, you are allowing the body to heal and create these new fibers and new smooth vessels. So resting is very, very important as well after doing any type of HIIT training and even resistance training.
So just a housekeeping comment. Genie, you have a patient starting at noon, don't you? Half an hour?
Yes, I do.
So we need to give you a break. Jesus, we're going to need to give me a break as well. Why don't we give it 5 more minutes? see what we
Sure,
can get done.
absolutely. Bobby Ocampo, I hope prolonged water fast and effect with CIMT results on soft plaque and hard plaque be conducted. 7 days, 14 days up to 40 days water fast. So Bobby Ocampo is always offering really good examples of what research can be done on this space.
Hmm.
And researching prolonged fasting and CIMT, you don't have that much research measuring soft plaque with CIMT or other things than a calcium score. So it's a good point. Um, there's some discussion about technical issues that we're having. Jim Dandy, harder exercise, more oxidation of lipids. What do you think, Doc? I don't think I have seen specific research on that. Sounds like a good assumption, but
Um, uh, I'm struggling because I think there may be some validity to the assumption. However, I'm not sure if there's an assumption that there's I think there can be an assumption that oxidized LDL is what's associated with plaque.
hmm,
So if you interpret that to say, oh yeah, harder exercise is going to create more oxidized LDL and therefore more plaque, I can't agree with that.
now
I
maybe
mean, we know
maybe it's
that.
just in oxidation instead of metabolization of lipids, which are two different things.
Yeah, they are two very different things.
Bootcamp 21. What's the difference between vigorous and very vigorous? Well, the researchers use metabolic equivalents, METs, and they said 7 to 9 as vigorous. Anything above 9 METs was very vigorous. And for athletes, it's not that hard to get above 9 METs. For the
Yeah,
casual person, it might be.
go ahead.
No, no, no. That was my comment.
There were a couple of other questions there. One, I think we're getting an echo. So one was an anaerobic state. And the bottom line is yes, when you do the intense phase of a high intensity interval, yes, you're going into anaerobics during that. There's no way your aerobic uh, mechanisms can keep up. And that is exactly the point. There's other types of, that's one of the points. There are other types of work, more of, what is it? Is the level 3 running stuff that's just slightly beyond the anaerobic cut point. And the goal behind that kind of training is to increase and improve your aerobic capacity. This is not exactly that. This is going much deeper, much higher in, or much deeper into an anaerobic state. Um, and it's not because somebody thinks it's cool, it's because the evidence supports it. Um, that going deep for just short amounts, about a minute at a time, 30 seconds to 90 seconds, really helps stimulate your body for this muscle microvasculature.
Pretty good. And I think we just have one more question right here. Clifford Marshall Von Buren. What about supplemental calcium? I see some reports that it is now a contribution to increasing risk.
Yeah, that's been known for quite a while, Clifford. There's risk associated with supplementing calcium. They used to talk about supplementing with calcium for a long time, but not anymore. Hey, Jesus, you want to end with our standard recommendation for high intensity intervals, just so that people know what we're talking about?
Sure. So what we do recommend is getting to intense exercising, reaching at least 120, 130 beats per minute at the point that you are gasping and gasping for air during 1 minute. After that, you want to rest for at least 1 minute with uh, absolute complete rest or just mild movement, and you want to repeat those at least 10 times. That will give you around 20 minutes of exercise 2 times a week, or 8 times 3 times a week. Now, the type of exercise that you can use to get to that can be either cycling, uphill, walking, running. On a treadmill can help for that. Some people have pelotons for that. Doing stuff like squats or sometimes of that type of exercise also helps. Do you have any another example of types of exercise for that?
The ones that I most commonly do are treadmill hill runs. One of the more common ones, I think somebody mentioned it a minute ago, cycling. Road cycling is very popular. It's great. In many ways, it would be the optimum exercise. However, there's a major problem, and it's called cars, and it's called bicycle wrecks, and they're very prevalent. If it weren't for those, I'd be a major fan of road cycling, because it gets those big muscles. We don't want, when you talk about working out, most men especially think about their arms, their guns. Arnold Schwarzenegger has huge arms. The bottom line, though, is if you look at his muscle mass, it's in his legs. It's not in his arms.
Yeah, and even
So
swimming might help, but swimming might be hard as well. Just to coordinate your breathings might be hard, but you can get there as well with swimming.
Yep. So thank you very much. It was a great show. And again, this is a big item. Most folks, one of the last things they begin to develop and understand is the importance of high intensity intervals. And it's because it's uncomfortable. Getting old and preventing getting unhealthy is just not for sissies.
That's for sure.
Very true.
See you next week.
Thank you, Jeannie. Thanks. Hey,
See you later. Bye-bye.
Bye-bye.